We should go ahead and start. It's an odd time for seminars. People try to catch water or snack before coming so that they can go back to their classes and other obligations. But I'm really delighted that we have this turnout. My name is Debra. I'm chair of the Department of Population Health and Disease Prevention. Today, we're very lucky to have a growth, I'd say, the collaboration between the Program in Public Health and the Department of Emergency Medicine in the School of Medicine. And that growth is here with us today in the person of Dr. Debra Houry, who is at Emory University, and she's Vice Chair for Research and Associate Professor in the Department of Emergency Medicine at that university. But she also has appointments in the Department of Behavioral Science and Health Education and in the Department of Environmental and Occupational Health at the Rawlings School of Public Health. So she has been working in the spirit of this kind of collaboration that we have here at UCI, also at Emory. She also directs the Center for Injury Control at the School of Public Health and teaches several courses on violence and injury prevention. She's on the board of directors for the Society for Advancement of Violence and Injury Research and the president-elect for the Society for Academic Emergency Medicine. Please join me to welcome Dr. Debra Houry.
Well, thank you all for coming today and flew in this morning, so feel free to pepper me with questions to keep me awake as well. And as he said, I'm
sorry, maybe I knew we would have a traffic flow. I said, come on in, please. Yeah.
It's on the wrong room number.
Yeah, it's kind of hard to find, and people will. Well, please come in, and then I just introduce us to the time. Oh, yeah. Why somebody right? Yeah.
There's no cherry.
Oh, I know. It feels weird.
Okay, I think that's about it. This is what I was expecting. I was a little bit shocked at but I knew it had to do with the directions of the course. But so now it's a very, very popular topic. Now we're really ready to start. Thank you. So for those who just joined us, I introduced Dr. Debra Houry. She's wears many hats at the Emory University in Atlanta. She's Vice Chair for Research in the Department of Emergency Medicine there. And she also has appointments in behavioral science and in environmental and occupational health at Emory University. We already clapped for her, but you're welcome to do it again because I'm sure the talk
And I am an emergency physician, so I have a short attention span. So feel free to ask questions throughout the presentation. You don't have to wait till the end, or I may what I was speaking about. I focused today's talk much more public health oriented on some of my research. Tomorrow I'm speaking with emergency medicine. It's that much more of a clinical talk about the work I do with violence. I just got started in this research when I was a medical student because I wanted to get into a good residency program. Didn't really know that I was going to end up, one, being a researcher, and two, this would be a field that I've done for the past 15 years. Got a combined master's in public health while in medical school, and just really found that in the emergency department, there's just so many ways that you can really impact patients from a primary prevention and secondary prevention standpoint, that it made a lot of sense to really kind of mirror what I did from a research and academic standpoint with my clinical standpoint. So I think I'm lucky because I enjoy what I do and it's fun, and I at least think it makes sense. A lot of people think what I do is schizophrenic and all over the place, but I think it comes together. So today what I wanted to really talk about was about intimate partner violence screening and whether it's effective. Talk about some of the work that I've done in the emergency department and how these results might apply to the general community. So how many are familiar with what the rule of thumb actually means? More than I would have thought, because I had no idea what it meant. I mean, I knew it meant something about your thumb, but I did not realize that that was the size of a switch that you could hit your wife with. That was a legal precedent. If the switch was smaller than your thumb, that was okay. I thought it had something to do with measurement or something like that, but I mean, so when you talk about it, I mean, it really just goes to show that although we've come quite far, it was not that long ago that this was a legal precedent, and up until about 20 to 30 years ago, spousal rape was still legal in many states. So we often look at other developing countries, but when you look at our own country, we still have a ways to go, and it's only been a recent history that we ourselves allowed intimate partner violence to happen. And when I talk about it, it's really about coercive behavior leading to abuse, physical, sexual, or psychological. It can be any or all of those. And one partner by the other, and the establishment of power and control, can be a current or a past relationship. And this relationship doesn't have to be marital, it can be dating, it can be same-sex. And in this talk today, I'm going to be using she as the victim, he as the perpetrator. I'm very aware that men can be victims and females can be perpetrators, and actually a lot of my more recent research has shown that those rates are actually equalizing, so where you're seeing higher rates of female perpetration and male victimization. When you look at dating violence, you're actually seeing higher rates of female perpetration. But today, when I'm using she as victim, I am cognizant and aware that this is not always the case. So why is it important? Because battering is the most common cause of injury to women in the United States. And when I think about how busy our emergency departments are, the impact of morbidity and mortality that we could influence, I think it's highly imperative that we look at this issue. You look at almost $6 billion on an annual basis for medical expenses and work productivity losses, and over 1,000 women and 440 men killed each year from intimate partner violence. When you look at common conditions affecting women between ages 15 and 45, intimate partner violence is one of the most common risk factors that women are exposed to. Bless you. And I didn't pull up the California stats today, I've got them for tomorrow, but the California Women's Population Study actually said that about 40% of women had experienced physical violence in their lifetime. So rates can really range depending on what your definitions are, but very, very common and prevalent. When you look in the emergency department, it depends on whether you're talking about non-physical or physical. And when they talk about incidents, the patient may not always be there for an actual injury. It might be mental health issues associated with the violence, or they might just be there and report they are a current victim. So the rates can range anywhere from 12 to 20%. And when you look at prevalence for lifetime, it can be up to half of emergency department patients have experienced violence from a partner. So from that standpoint, it made sense to me to really look at the emergency department as a place to study this. You know, it's a point of entry into the healthcare system. If you fall and break your arm, you're going to come see me. If you don't have a primary care physician, you're going to come see me. So no matter what your socioeconomic status is, you're going to come see me at some point. You may not want to hear that, but you know, you really can see everybody from all walks of life. We do usually serve the medically and underserved and those without insurance disproportionately, but anybody that has a violent injury will come see us. We see a lot of victims of trauma. The county hospital I work at, we see 110,000 patients a year, only level 1 trauma center in Atlanta. Just, I worked Saturday, had 5 shooting cases, you know, so we see victims of trauma all the time. Really, it's an important time to really develop an educational intervention. It's really the teachable moment. We also see people with substance abuse problems and mental health problems that, again, don't have regular access to health care or to other primary care providers. But when you look at it nationally, these have seen over 115 million visits, increasing each year in the number of visits that we're seeing nationally. And at the same time, the number of hospitals are decreasing. So we're having increased volume, decreased places to go, and we've seen that 20 trauma centers have recently closed. I know in California you guys are very familiar with some of the recent trauma center closures. That's because we do lose money. We see a lot of uninsured patients, trauma patients that usually generate money, but again, this is where patients go. So with that in mind, this is what I see every day when I go to work. This is just during the day, so not a Friday or Saturday night. The ambulance is parked, just waiting, you know, to bring me my patients and clients. And this is the waiting room. You can't see it as well, but you know, it's not this big, beautiful waiting room with trees and plants. I teach a comparative healthcare system course, and I make my students come with me to my county hospital before we go to London, because usually people, when they go to London, think, oh, the healthcare facilities aren't that great. But when they've seen what some county facilities are in the United States, they actually think, you know, that the facilities in London are quite nice. I think it's, a lot of times it's what you're exposed to. So this is our waiting room. We usually have, it's gotten better, but sometimes we can have up to 12 to 15 hours waiting time to get seen. I've suggested putting educational videos there instead of like the news or Oprah, but that hasn't happened yet because again, you've got that captured audience where they're sitting there, and to me it's a great time to do intervention. So I've actually put kiosks there, which I'll talk about. The other thing is this was our fancy triage area. It went computerized 2 months ago, but before that, that was how we sorted patients, literally medical charts going in different baskets.
How much of the traffic would you say costs money, but they don't really need emergency care?
Probably about 30% of our patients. So not as high as people think. People think, you know, it's because we have so many of those patients that don't have access to health care, but those patients are easy. You know, they're the ones that come in with a medication refill, and so we can see them quickly. It's the patients that have longer, more complex illnesses. And because despite, you know, some of these mandates, people have more insurance, it doesn't mean there's more primary care physicians, so now patients want access to medical care, so they come see us. So this is, again, just a regular day for us. Our hallways, they're all marked. We have 19 on our trauma side and I think 20 on our medical side. And so patients will then come here. And you can see, again, the emergency department, I think it's a great place to do an intervention. But when you're looking at something like this, it may not be the most private, the most conducive, you know, to really talking about private and sensitive issues. Particularly, you know, when you're asking a question and the patient, the bed behind you, will answer because they've already heard the patient ask that question before and helpfully correct you. And on Halloween, we actually switched to a computerized system, but prior to that, this was our fancy ordering and tracking systems, again, for 110,000 patients a year. So just paper and clipboards, and all of our charts were paper too. So when you're looking at doing studies where you're extracting data or trying to do any sort of surveillance system, this is what you're working with. And so when we're talking about my studies, this is what I was working with. And so when I always talk about some of my research, I say, you know, I was able to do it in my setting, it means that it can actually be done, I think, easily in other settings. And the other thing is patient experiences in the emergency department. They come, you know, and then if it's like a car crash, we surround you, we cut your clothes off, you know, everything's happening all at once. Somebody comes in after a trauma, we just swarm like a herd of bees. And it can be really traumatic for a patient as well when you're trying to do psychological debriefing or counseling or anything like that. This is the setting we're doing it in. So again, really kind of high stress, not as probably conducive as if it was a one-on-one setting outside. So with that in mind, When you look at the emergency department setting, many patients with intimate partner violence present with non-injury related complaints, like chronic abdominal pain, depression, suicidal thoughts. And they don't just come in with, a broken leg or a laceration from their partner. But when you look at how we've done in the healthcare setting, screening rates usually are about 10% where we're screening men and women for intimate partner violence. It's really abysmal. But, we've got all these patients coming in with violence-related experiences. A lot of people say, well, patients don't want to be asked. They do. We've surveyed men and women, 85% feel it's appropriate for health providers to ask about violence. We ask about seatbelt use, smoking, everything else, so you just ask about your kind of regular routine delivery of care. When you look at the American Medical Association, they actually say that we should be doing routine screening at the entry point of healthcare, which is really emergency medicine. It's also your primary care physician's office, but in my mind, emergency medicine is really on the forefront of this. And JACO, the Joint Commission on Hospital Accreditation, the ones that set all the rules and say, you can't drink sodas while at work or have snacks out. They also say that you should be screening and referring patients. But when you actually look, there was a study done in California, actually, where they saw who knew what their protocols were. Less than half of hospitals even knew what their protocols and policies were. And when I first went to Emory, I was very excited. Like my first month, my medical director had asked me for a screening question to incorporate in triage. I was like, this is so great. I've just moved to Atlanta from Colorado, and we're already going to, do this intimate partner violence screening. And I didn't realize we had the JACO site visit coming up soon. We wanted to make sure that we had that screening question, that we were incorporating because it was mandated. I'm okay with that because at least hopefully it's getting asked or recognized. But in places to where they don't even realize that there's the mandate and it's on a form, probably not as effective. When you look at universal screening, screening everybody for intimate partner violence, as some people in places advocate. Greg Larkin, when he was at Pittsburgh, trained all of the nurses through like a 2-hour video, an educational session on what to look for, how to ask the questions, and what to do with that information. On the triage sheet, when every patient came in, there was the box that they were supposed to check with the assessment. And after this great educational intervention, less than a third were screened. Again, after they're told this was mandated and having a focused educational session on it. Day shift, being less sick, more likely to be screened, which makes sense when you're not quite as busy. Somebody's coming in not having a heart attack, you might ask. But again, 70% of our patients, wouldn't be explained by this. So people just aren't asking. So they took it a step further, and they actually implemented disciplinary action if you weren't screening. To where if they reviewed your charts and you hadn't been screening, you then got verbal counseling. Half of the nursing staff got verbal counseling. Hi Betty, we reviewed your charts for the last month. It looks like you've not been screening for intimate partner violence. We had this session in October. Please screen. It's important, from a public health standpoint. Next step was written counseling. Hey Jack, you were given written or verbal warning 6 months ago that you weren't screening. We went over what you needed to do. We've not seen any improvement in your screening. Please screen. Third step was written warning of termination. They would actually lose their job for not screening. 10% of people got to that. The fourth step was termination. No one got to that step. But when you look at what screening increased to, 73%, so still not even 100%. And that was being told you could be fired if you weren't being screened. Yes?
I'm sure you're going to get to this, but is there a reason offered as to why these nurses didn't want to do the screening?
You tell me. What are your thoughts?
Well, I have some thoughts as to why, but are you going to...
Not specifically for this study, but at the end I'll talk about kind of Pandora's box, as I call it. But what would be some of your initial thoughts?
Well, I guess my first question would be, what did they do if somebody's screened positive? Right. What was the step that they were supposed to follow?
And that's the big what if. If you ask the question, you get a yes, and you're already busy, then you're supposed to stop everything. Refer to social work. Maybe there's kids involved, and you just really open up this huge box. Sometimes it hits too close to home, or you don't think it's necessarily important because you might think that there really aren't many effective interventions, or you've seen where you've referred people before and they still keep coming back. And so I think all of those really come into play, but the biggest one is you get that yes answer. And what's amazing is a lot of times when you see screening, you can see how people can look at someone and say, you know, I don't think she smokes and I don't think she experiences violence, because they can just check no, like all the way down a chart without ever having lifted their pen. And sometimes I'm not really sure that people are actually screening versus just looking at people and determining yes or no. So I've gone back and done chart audits, you can see clear histories where patients truly were there with suspicious injuries and was marked no, and I don't think was ever asked. But yeah, it's because in general people don't want to take that extra time to follow through, which is why I developed the kiosk intervention. You know, and so should we screen? The U.S. Preventative Services Task Force has given it both a C and an I for insufficient evidence for insufficient partner violence screening. And several recent systematic reviews have just said that, you know, there's really not enough information around the harm or benefit of identifying and treating abused women. But I think it matters, because if you don't ask, you're not going to detect it. People don't volunteer this sensitive information to you. If we don't pick up on it, they're going to come back with worse injuries, or their children are going to be injured, or a family member is going to be injured, or they're going to come back dead. It's low cost to ask. And if we do it in a safe manner, it's low risk. You know, so does it predict future violence? This is one of my first no-duh studies. Took several journals to get it published because they all kept saying, well, we know this. But we actually didn't know this. I was looking at the predictive validity of screening. We looked at women who screened positive and negative at 0.0 and followed them over a 4-month time period. And what we found was anyone that had screened positive initially, 11 times more likely to experience physical violence during that time period, and 7 times more likely to experience verbal aggression. Anybody that sought medical treatment in that time period for an injury had all screened positive. So you are picking up patients who are experiencing violence, and by recognizing, hopefully you can prevent some of that future injury. You know, is there an easier way to identify and really educate? So my own personal bias is computer kiosks. It takes the really embarrassment off of going up to somebody and asking about personal questions. You know, like, did your partner hit you at home? And people don't want to tell me that after I've just, you know, asked them their name and checked their blood pressure. That's the next question I ask. You know, we don't have a long-standing relationship. They're able to do targeted resources or intervention off the kiosk based on what people screen. And in my mind, it's great for environments with a long waiting time. I mean, I've got greater than 80% acceptance rate in my kiosks. People will go up and do them because it gives them something to do while they're waiting. What I've actually done is put other public health measures on there, like substance abuse, mental health issues, to really give them referrals and help identify any issues that they have while they're there. And physicians and nurses are really unlikely to screen. And so this takes the burden of screening off of the healthcare providers. And if you get that yes, it automatically links their yes to targeted referrals. So then you don't even have to worry about what happens if you now give the physician the piece of paper with the information and they don't follow up on it. The kiosk automatically will do that. So what I did was I wanted to see what the safety of screening and identifying and referring victims as part of this ED kiosk system were, to really look at future incidents of violence and patient-reported outcomes over a 6-month period. And again, this was in my county hospital. And it was supported by both CDC and NIH. And this is what our initial touchscreen kiosk looked like. Now I'm on a newer study, and it actually looks like an ATM machine, and it's very fancy looking to where you can't miss it. My initial request for a kiosk was something that they couldn't pull through the registration window because we can't even have like things to look in your ears in our hospital because like they walk off. I mean, so I needed something big they couldn't pull through the window, and something really heavy and indestructible, and that lasted for 3 years. So you know, and it cost $2,000. So in my mind, very cost effective. It was also in a semi-private registration booth. That way the person sitting next to them couldn't see what they were putting in, so they felt like they were private. I also positioned it right by the security guards when people came in after they'd been screened through the metal detector, so if there were any issues, again, security was right there. We had no issues, but these were all the things I was thinking about when I developed it. And that's actually not a patient either, that's my deputy director who I asked to pose for it. And what we looked at was harm from participation in screening. Because one of the arguments against intimate partner violence screening is that it's going to increase your harm. You know, she might feel empowered and go home and shoot him, or he might hear she participated and then retaliate. And my thought was always, if you do it where you don't label intimate partner violence, give them safe instructions, you know, tell them to, if they're going to keep the referrals, put them in a shoe or a small safe place, and just don't say, you know, you have these issues, it's safe. And to really look and see what did they do with this information. Did they follow the resources, contact the hotline, did they develop a safety plan? And how many incidents of violence did they experience after participating? So what we did is we approached the emergency department waiting room. I had research staff assistants would walk up to every single person after they've been triaged, men and women, and say, we've got a general health survey we'd like you to take. They were not told it was violence because, again, we didn't want to predispose people or increase their risk by taking it. They then were taken to the computer screen where they would do their consent, and then we got a printout if anybody screened positive for intimate partner violence for the research staff for something, enroll this patient in the study. And so then we would follow them up at 1 week and 3 months. And the other thing we did was, because in general, follow-up is really difficult in people experiencing violence and in our county patient population. So we looked at 911 calls to their addresses before and after. That way we never got a hold of people again. We had a general sense for what was going on.
Good question.
Yes?
Were the patients aware that they were enrolled in the study at that point when you called?
Yes. Well, we didn't call about 911 calls. Like whenever anybody went to do the screen, they were all consented to this general health questionnaire. And we got their address and all that information at that time. If they screened positive for intimate partner violence, then they did a second consent because we had them come back to meet in person or do phone follow-ups. And what we did was, there was 120 questions, but they didn't answer 120 questions. We had skip patterns in there, so if you answered yes or no to some things, you might skip 20 questions. So it really took about 15 minutes. And you saw the booth that it was conducted in. We used validated scales, which I'll cover, and we also had things, demographic information, height, weight, because we were calculating their BMI, so we can give nutrition information, primary care referrals, everything. Because again, although this was a research study, I thought it was really a service to our patients that they were doing this. And the way how I got people to enroll too was I offered them a healthy snack, and they got the peanut butter and crackers or the cheese and crackers, which I know aren't really healthy, but I just didn't feel good giving them candy bars. And when we did granola bars, no one was interested. So that was kind of my compromise. And that was their total payment. If they did the follow-up interviews, they got paid $20 to come back, but they got a package of crackers to do the 15-minute computer survey. And again, when we found people had screened positive, the research staff would get a printout, and then they would know to get their contact information. I also had suicide questions on there. And if somebody was suicidal, we wanted to know. So we had that printout because we didn't want them to then sit in the waiting room for 12 hours after having disclosed suicidality to our computer. I thought that was a big risk to have somebody perhaps leave after having documented that. So that patient would then be moved out of the waiting room and brought back sooner to be assessed by a physician. Because mind you, these patients weren't coming in for suicidal ideation because they would have gone through our psyche arc. Initially, these are patients that were there for like an ankle pain, and then but disclosed they were actively suicidal.
So how common was that?
So that was one of the lessons learned. Actually, hold that thought for 2 minutes. So this is what we used for intimate partner violence. It's called the Universal Violence Prevention Screening Protocol, and I liked it because we validated it in our Grady population before. And these are the questions. Because it asks about physical, sexual, and non-physical violence. And so I thought it was important because many only ask about physical violence. And this, is it a perfect test? No. Is it, 20 questions? No. But again, I just want something simple to really pick up where there are issues. For depression, we used the Beck Depression Inventory, and I just broke it off by none to mild or moderate to severe. With PTSD, we actually added a screener about traumatic events. That way, if they hadn't experienced anything, they didn't go on to ask the whole PDS. And then with suicide, what we did was we looked at the Beck scale, and I looked at all the literature, and it ranged from 2 to 11. We initially had a lower range, I think maybe 3 or 4. We found very high rates of suicidal thoughts in our patients, whereas disrupting patient flow, and was not very good for our clinical practice. And so I contacted Dr. Beck and looked at all the studies, found what the highest cutoff used was, and that was 11. And so that's what we went with. And I'll show you the results in a few minutes about what our general population rates still were with the highest cutoff. But yes, I modified it after piloting it because we had extremely high rates in our population. And then at the follow-up, just with those who disclosed victimization, we did a complex tactic scale assessment, danger assessment, stages of change, the short form 12 to look at physical and mental health issues, as well as some victim desired outcomes like safety plan, leaving their partner, telling family and friends, and follow-up questions about the violence they experienced. And these were the main victim desired outcomes that we looked at. So over a 17-month period, we approached about 5,000 people, found about 4,000 were eligible. They had to be English speaking between the ages of 18 to 55. It was really during the high peak hours of when I had people screening. And we had 70% participate in screening. And this is just our general, population. A little over half were male, age was about 35. Education level is actually higher than I thought it would be. 59% had at least gone to high school. When you look at usually our medical literacy rate, it's around 5th or 6th grade in this population. So all of our tools and information was also tailored to that educational level. Majority of our patients were African American, 87%. Half smoke cigarettes regularly. 21% have used street drugs in the past month. In the past month. IV drug use less common among my patients. It's crack cocaine is what's used in Atlanta. It's very regional. When I trained in Colorado, it was more heroin. Here, it's all crack cocaine that you see. Half have used alcohol in the past month, which isn't a big deal, except when you look at kind of the problem drinking questions. And, a third to 40% are problem drinkers. So this gives you a sense for, again, the general patient population. And when you look at their mental health symptoms, 25% were experiencing moderate to severe depression, 13% moderate to severe PTSD symptoms, and 7% suicidal. And this really opened a lot of eyes, particularly my own, because I'm an ER doc at heart. I treat them and street them, as I always say, and I only want one patient complaint because I'm not that complex of a person. But then I realized that everybody is really multifactorial and multi-level, and that there's all these mental health components going on, and our patients are constantly exposed to traumatic events around them. To where, I actually don't, and we'll talk about it, and I don't recommend asking the question, do you feel safe at home? Because many of my patients don't feel safe at home, and it has absolutely nothing to do with their relationship. It has to do that, there's a lot of crime near them. And that's why you see such high rates of mental health issues. So we then looked at people who were in a relationship in the past year. About a third were, or 2/3 were. And of those, about 36% disclosed intimate partner violence in the past year. Majority were female, tend to be younger and unemployed compared to those who did not disclose it. And when you look at associations with intimate partner violence, you can really see significance with depression, PTSD, suicidality, drinking, and street drugs. All were significant. What I don't have today is my perpetrator information, but it looked essentially the same as well. So whether you're a victim or a perpetrator of violence, high-risk associations with mental health symptoms, substance abuse, and mental health. Again, you can't just screen for one thing without considering everything else.
So there were more males in this pool?
Well, in this pool, it was about 67% females among the victims. But pretty close to that for the perpetrators. I think it was close to 50-50. But you really just saw this breakdown. The other thing I did is I looked more at power and control to see where people fell along the spectrum. I did find that females who disclosed victimization felt greater loss of power and control than men who were victims. So there was really kind of a different battering level that was going on with it. And what oh, sorry, yes.
On the last slide, what were on the verses, the different percentages?
Oh, those that were not victims. So 39% of victims disclosed that they were depressed versus 11% of people who were not victims. Yes.
I'm sorry, so you knew that they were a victim and or a perpetrator from how they responded to the CTS? Everybody was asked whether they were?
If you were in a relationship in the past year, then everybody got asked the Universal Violence Prevention Screening Protocol, and I had a perpetration screener on there too.
Okay, and you asked only the patient, or could anybody in the waiting
Just, no, just the patient, because it was all anonymous and on the computer. So, and I did not ask for validation from anybody whether or not they thought the person was a perpetrator or a victim. And what we found too is if you looked at the types of violence and mental health symptoms, you can really see this huge dose-response ratio, to where if you experience both non-physical, physical, and sexual violence, up to an 18-fold risk that you disclose suicidal ideation compared to somebody that had no exposure to violence. You can just really see each type of violence just really is very additive. And so our follow-up was not as great as we would have liked, and I'll talk about lessons learned in a second, but of the 548 who screened positive, 430 agreed to participate in the follow-up, and it was interesting. Reasons for not wanting to participate were usually, I'm not a victim. When you look at what they screened positive to, you know, they were being hit or threatened. So we did education around that time too. We did get 62% for 1 week follow-ups. And we added the phone interview there because many people just didn't want to come back. So we tried to at least capture the safety information. No one had any problems in the emergency department after they were given the information targeted around violence. Their partners didn't try to interfere. There were no security incidents, anything like that. 2 didn't like the questions that we asked because, particularly the conflict tactics scale, they thought they were just very personal. But there were no violent incidents after participating. 95% felt they benefited, and 83% kept the information. And I am aware this is self-report, so they might be telling me what I want to hear. But when you look at what happened, a fourth made a safety plan. 15% actually contacted resources. And this is the patient population that when they come in with chest pain and we schedule them for an outpatient stress test, there's about a 10% follow-up rate. So to have this high of results when people are entering substance abuse treatment, contacting resources and all was very impressive. The one thing we did have to change in the script when we did our first interim analysis was people start carrying weapons. And I didn't think any of my federal funders would appreciate if patients, after participating in my study, started carrying weapons. So when we were going over safety plans and or appropriate responses, we put in there that carrying a weapon, you know, was not recommended. It could actually increase the risk of harm. So after the first couple months where this went up, I think we only had 1 or 2 people carry a weapon after participating. I was very alarmed when I first saw that. At 3 months, we found, it was interesting, we looked to see who was following up, and those with more significant mental health symptoms were the ones that were coming. It was actually the population that we wanted to capture. They were the ones that had less social support as well, and so they were the ones that were coming back for our referrals. And again, at 3 months, we found that a third had contacted a resource, 20% had called an IPV group, and a third had moved out. So I think it was ABC. One of the local news cameras did a show on my program, and I was worried because they said, you know, we just want to grab one of your participants and talk to her. And I was thinking, okay, you know, I wasn't getting to pick who it was. We had no idea what they're going to say when they get to be on TV. And fortunately, it worked out very well. The woman said, you know, I've been in an abusive relationship for 7 years. I got coming to the emergency department. No one ever asked me about it. I didn't know that this was wrong. I didn't know there were resources. I didn't know there was help. And after getting the information, she joined the support group and left her partner. So that was a good story for TV. But I think that was just really clear that, I mean, no one is asking about it. And just saying, this is not right. If you grow up around it, you might think that it's all that there is, and you don't realize that there are other resources or referrals that you can get help with.
Good question.
Yes?
When you said that your population came back for the interviews and you made a safety plan, was that your social workers or?
Research staff, and it was just solely off the printed out information. Because we wanted to do something very low key. And the study I'm doing now is where we're taking the research staff completely out of it because we don't want to even have that counseling aspect because that costs money, you know, to have people there staffing it. It was just solely on a printed out piece of paper, a few paragraphs about what they could do.
And in addition, they contacted hotlines for groups?
They were given numbers on, like these are hotline numbers you can call, here's United Way, here's Legal Aid. And so then we tracked to see what they did.
So a quick question about your attrition rate between week 1 and
Yes.
3. Was that largely due to not being able to find the people, or was that due to their refusal?
Not being able to find it.
Okay.
Hold that for 1 second. So, and that's why we did these 911 calls, and we found no difference 6 months before or 6 months after to any of the participants that participated in the study. So we didn't see any increase in 911. But when we did lessons learned, I had to increase the cutoff score for suicidality. Because we had such a huge volume, we ended up doing 2 computers, that way we could run people through it multiple times. To get people to come to 1 week, we had to do daily phone call reminders for follow-up with pre-arranged schedule times. And that was to get, you know, like the 60 to 70% at 1 week. And what I did was I told them, here's your appointment to come back to us. But then they also knew when we were screening patients, so if by chance they were there for a follow-up appointment or happened to be there, they could also just drop by then and page us. For 3 months, we'd start doing weekly phone calls, we'd send them postcards, but I think half the people had disconnected phone numbers, usually even after a couple of days, and we tried looking through registration and get different phone numbers, and just could never find a lot of our patients. We also did murder tokens, that's our public transportation, because for a lot of our patients it was, you know, cost prohibitive to come back to see us. We didn't give them the tokens until they came, then they got reimbursed for both ways. We also were going to do exit interviews after the ED visit, but when we saw how long many of the patients were there, like 18 hours sometimes, they weren't filling out paper surveys, we couldn't get staff to do it, so we just took that part out. One of the other aspects we initially hoped to do was there were going to be 3 printouts. One for the patient, very detailed with safety plan resources, one for the staff saying enroll this person, and then one for the physician just saying they screen positive for, you know, sexually transmitted disease risk factors, alcohol, violence, and they would just get a prompt just saying what was positive for. These are paper charts at the time. We found that sometimes they didn't make it to the paper charts. If they did, it was like maybe 5 pages back behind, you know, the ambulance form or something else, and so they weren't getting read or noted, even noted half the time. We felt that was probably even worse because then the patients thought the physicians knew and weren't asking, so then we just took all of that away and just really had it kind of very kiosk-based. You know, other ways to screen, pre-exam questionnaire, screening by a triage nurse or someone else, modifying it on the chart. On our paper charts, we had a box for domestic violence, which I think is good because it can prompt you to ask, but again, you have to be in the mindset to even ask about it. And the other thing I'll say is, if you're going to have that box, like on a pre-exam questionnaire, you have to follow up on it. I was just curious to see what would happen, and when I was going to my OB for my visit, I checked the box because we said what you wanted to get information on, and I was curious to know what information they had. So I checked domestic violence, and triage nurse didn't ask me anything, the doctor didn't ask me anything, and then when she was getting ready to discharge me, I just said, well, you know, I checked the domestic violence box. She's like, oh yes, you did, Dr. Houry. She's like, is there anything, you know, you'd like to talk to me about? And I said, well, this is my whole area of research, and if I truly had been experiencing violence, and I checked yes, and you never followed up with me about it, you are endorsing this and saying it's okay. So then I asked, it made it worse, I asked to see the information, they couldn't find the pamphlet at that time, and I think I got a little star because every prenatal visit I had after that, I was asked about my situation at home, which has always been fine, but I just wanted to know. So I think, you know, if you have any of these mechanisms in place, you have to ask, and that's why with the kiosk, I like that if you do screen positive, you automatically get a printout, whether or not, you know, it gets disclosed to a physician. So my hope was, you know, to really involve providers in this. I think that our healthcare setting, with increasing visits, you know, decreasing places for people to go, It would be great if it could be done, but it's not gonna happen every time, and I worry about the person that is there that needs help, that doesn't get that referral. So I think it's really important to at least kind of have a fail-safe mechanism in place. You know, so why don't we screen, and this is my Pandora's box, you know, lack of education around it. People aren't comfortable asking the questions, or aren't really sure what we can do for our patients, and not realizing too that you can't just refer to social work. They may need a mental health referral, they might need help with their substance abuse issues. Lack of time, although I would say lack of time is if you get the yes, because it really doesn't take that much time to ask a single question. Lack of effective interventions. I think many people get frustrated because it can take up to 7 times before somebody leaves a relationship. And so you don't know where they are on the spectrum. When we look at stages of change, 80% were in pre-contemplation, not even realizing that they were having any issues, where the intimate partner violence was a problem in their life. And so you don't know where you are on that spectrum of moving people, and I think it can be frustrating for providers and for somebody like me where I'm very, you know, action-oriented, not to see, okay, I've discussed this with them, I've given their options, where are they still in their relationship? Because that might not be the outcome that they need. Just by asking in itself really is a benefit. Fear of offending the patient. You know, privacy concerns, they come in, you're asking all these detailed questions. And when you look at the numbers, a lot of us have been exposed to violence, and sometimes it is too personal and people aren't comfortable asking about it. And so why bother? Because if you don't ask about it, I really think it sends a message. It's amazing what a lot of our patients think we're able to tell by looking at them or talking with them when we really may not know what's going on. The cycle will not stop. You know, the injuries will get worse, the violence will escalate, can involve other people. And I really think that it's really that educational moment. When somebody comes in after a car crash, I say, were you wearing your seatbelt? They say yes, I say, thank you, that's why you look as good as you do today. They say no, I'm like, this is your lucky day, you know, you were so lucky, you really need to wear your seatbelt again. You know, and that's the time you can talk to people when they come into the emergency department or anywhere else disclosing violence or with some sort of associated problem with it. You can talk to them at that time because that might be when they're most receptive to it. And not talking about it today, I am tomorrow with emergency medicine. There's legal responsibilities too, depending on what state. California is a mandatory reporting state if you present with an injury from intimate partner violence. So, wrapping up, so there's a little bit of time for questions. Again, my personal bias, I think intimate partner violence screening is safe, and that when we link it with referrals, it might prevent future incidents. We found that most of the patients were satisfied with this computer process, and that many contacted follow-up referrals. And in general, I think computer kiosks can be really helpful for providing brief educational interventions in medical settings or other settings where you've got, you know, a large group of people with, you know, a waiting time, or where you can put them through before you talk to them about anything else. Resources, there's always the 1-800-799-SAFE number, which will link you up with the most local shelter. There's the California hotline as well. And nowadays with the internet, I mean, you can pretty much find anything just by Googling, you know, intimate partner violence and referrals. But the 1-800-799-SAFE number is a really important number to always know because, again, it can link you no matter where you are with your local resources. So that's it. Questions and comments?
As was to be expected, we had substantial attrition from the initial sign. We conducted analyses on nodes in the data from 1 week follow-up, 3-month follow-up, compared to the initial.
Yes.
So what background demographic factors differentiate who there as followed versus those who weren't?
Yeah.
What the level of violence initially?
We found really no difference in demographic factors, but a lot of it was because most of our patients already were like below quintile for income and getting some African American. When it came to violence, those were the most severe violence, and those were the most mental health issues were the ones that came back.
The ones that came back?
Yes.
The higher on effective right?
Yes.
And the PDF scores, what were the system levels?
It was all moderate to severe. I think it was like a 20 that we used as cutoff. So we found that everybody that came back, not everybody that came back, but those that came back were more likely to express higher mental health symptoms. Yeah. I mean, it's kind of good because the thing where those are the people that probably are most at meetings, and you hope that they're the ones coming back and they actually were.
So you described with the kiosk as the referral intervention and it seems to reduce the risk of intimate partner violence. My question is, you're thinking about, given limited resources in the emergency department, maybe physicians' reluctance to go through this, could the kiosk itself serve as some beneficial function? I know, as I'm just thinking, if you're going in a system that has nothing, we have an ideal, but we can do it in increments. The kiosk might serve that validation function that you're describing. Not the referral, not the whole social worker, everything, all, address the whole person, but just the validation, which could also be in these anonymous settings. So have you looked at just the effect, not that that's what you intend to do in the first place, because you have such an amazing, potentially amazing intervention. How about just the bare bones kiosk?
And that's what we're looking at now is kind of what level does it take? Like, will people just go up to the kiosk? If it's sitting in the waiting room, do they need signs to go up to it? Will they actually contact anything on their own they get from the printed information? So we're looking at the translational component of it now, how we're going to make it most effective. So we're studying that now. And the other thing we're looking at, we've called 200 administrators, hospital administrators, to see, would you be interested in technology like this, in your medical facility? Most say yes if it's free. And then it's sort of maintenance and they're not as interested in it. But the thing we found too is we're doing it in 3 different hospital systems now. There's different firewalls, different internet issues, even just physical layouts. Like, if they're not going to be supportive of it, it was amazing. I've gone to some where the chairs are moved around and things are thrown over the kiosk like a sheet to where like you wouldn't even know where to find it. And so even just having the kiosk itself requires a little bit of maintenance and support.
Is Georgia a mandatory reporting state, and how would that work in California? You're screening people, and can you tie into your answer? Your sensitivity and specificity was good, but certainly not high enough, perhaps, that we want to start calling the police in.
Well, the law is for if you're there for an injury from intimate partner violence, and it's a medical provider that's supposed to report it. So a kiosk is a survey. So it's not a medical provider, and they're not asking about the injury that you're there for today. They're asking about experiences within the past year. So from that standpoint, it would fall under reporting. Georgia is not technically a mandatory reporting state. There's 45 states that have like laws for injuries from firearms and so forth. Georgia's law is that if you believe somebody is there for an injury from a non-accidental means, you're supposed to report to the person in charge of the facility, who will then notify law enforcement.
So you think in California we could do the same thing as long as we don't ask particular questions that go
With what they're for today.
Yeah.
So because I'm actually going to do is looking at the link between child maltreatment and intimate partner violence, and I try to navigate the IRB about it. If I just ask more general type questions, you can ask some of those. If you're looking at and for things like imminent harm, like I had some homicidal and suicidal questions, and that's why I had to print out in my consent form too. Patients were told that if they disclosed, significant suicidal ideation, they would, be what we call 1013, put on a mental health hold and go to our psych ED. So we did have to do that with some of our patients. Yes.
I guess I have 2 questions. The first kind of piggybacks on some of these. You've seen in this protocol right now, you're having a lot of really positive outcomes, including fewer 911 calls. Do you think that that seems that's kind of, you're not exactly revenue neutral. You're making money by doing that. Do you think that would be, a source of support for this sort of program in the future?
That was my hope. I had gone towards several foundations that were initially interested because I was willing to just, I've developed this program, these questionnaires, to have it internet-based where different facilities could deploy, but I wanted to really pilot test it in a few other settings and different languages first. In my mind, it makes sense. Although this is secondary prevention, and I do think we need to focus on primary prevention as well, because it's great that we're finding people now, but if we could even stop the violence before it happened, that would be wonderful. So, but no, I think something like this is easy to do. We should be doing more of it.
I guess that second sort of more related question. Do you have any idea of the kind of, the penetrance of the people of the people who took the survey out of everyone who came into the ED, and specifically how many people who were in the ED that took the survey and who were positive for IPV. I could see, if you are like in ED with like an IPV related injury and your partner's right near you, they probably won't let you,
Well, they wouldn't if they knew that's what it was about.
Right.
But we asked everybody to come talk about, general health questions. And we separated them from their partner whenever we did that. We did document if there was any partner that seemed kind of controlling. I think we had 2 or 3 cases of that in general. But people are used to being, and I had my staff wear coats too, because initially no one wanted to talk to them, but when they were wearing white coats, everybody wanted to talk to them. And so, they would pull people aside and say, do you want to do this? And so about, 70–80% of people would do it. I'm sure we missed some, and we also did in the waiting room. Somebody that was really sick, like a shooting or stabbing or anything like that, they weren't screening. We talked about doing like a tablet to where we could go around, but we may at some point. I was just worried about interface with the printers and to be honest, losing all the tablets.
But there was a kind of gatekeeper, like one of your staff members.
Yes.
But I guess going forward, you mentioned seeing how few staff members you could involve with this.
Right.
Would you anticipate any sort of problems where it's just kind of, you're in the waiting room, like here's a sign that says do this survey, and it's not complete privacy there, and you might have someone else.
I think probably people will be less likely to do it unless you can build it into triage, where they say, like Southwestern, you can actually, the emergency department in Dallas, you do your own, like registering your chief complaint and stuff like that in the kiosk computer at that time. So if you could link it to something like that, to where your primary care physician gives you your checklist, where you say, go do this, and then we'll see you. Then I think you would have, higher rates. Yeah, the partner definitely could be there for it and help them fill it out, so you wouldn't get the information you need. But I think you're still going to get enough people that you can probably help.
So I was unclear at the end of the survey, because they were told it was just a general survey, and at the end.
And it was, we had questions about all sorts of help.
Yeah, but if they got a printout about the resources for IPD, then were they given some sort of explanation about like person contact as opposed to just a handout?
Well, whatever you screen positive for, you got resources for. So if you screen positive for not having a smoke detector in your house, you were given information on how important it is to have a smoke detector in your house. So anything like that. But if there were IPV, I think we call it relationship issues, because we've done pilot testing with what was comfortable for patients exposed to violence that you even have on a piece of paper. And like with perpetration called anger management, they were then told that they could enroll in the second part of the study for follow-up. So, and if people didn't want it, they still got the violence information.
And was it more than just phone numbers? Was it, more than hotline things?
It was like 2 paragraphs on like developing safety plans, a general paragraph about what, is kind of normal relationship behavior, things like that. We kept it as basic as possible, so we didn't want to give people a huge stack of papers that they weren't going to read. So it was like a paragraph with resources by issue.
And then for the follow-up interviews, other than by taking action with a follow or with a safety plan, and you showed the list, were there any significant predictors between those who had taken action and those who hadn't?
Not really, but our sample size was small.
And did having children at all listed as significant factor?
It's a great question. I don't recall that offhand. My guess is it probably didn't, because I don't remember anything that predicted one way or the other. Yes?
Of the women who did follow up with the services, how effective did they find them in
Yeah, and that's a great question. We didn't ask that because we were only following like even up to 3 months, because we knew by 6 months we'd have 10% of our patients less. So we just asked if they kind of contacted resources if they found them helpful, but we didn't ask specific things like, from that, did you do this? But we also did look at the other outcomes that they had. So we could look at if people use this hotline, were they more likely to then have a safety plan, change their locks, etc. But again, at that point, I think at 3 months we only had 130 people, so probably like 20% contacting one resource, so we just didn't have the numbers to.
So of your several, who had contacted at least one resource, they tended to contact multiple rather than?
Not necessarily, but if we're then trying to compare, we'd have like 20 who contacted the hotline, maybe 15 people that went to support group, 10 that went to a mental health counselor, and so just not large enough numbers to really look at it, other than just saying, you know, of these 10, 8 did this.
You mentioned about 80% of your sample was kind of in the pre-consultation stage.
The kiosk move people. Not as much as I had hoped. And when I actually presented to the CDC, I said I feel really bad because we didn't move people along the continuum. They said, actually, you know, these measures sometimes, you know, don't pick up on smaller movements, and the victim desired outcomes could actually be considered more movement along that continuum. But yeah, we did not move many people like we had hoped. I want to see everybody move to like action and plan, but it did. But people were still taking some actions. But I think just globally they had to move stages.
Okay, thank you
Well,
very
thank
much.
you guys. It was great to be here. Thank you again.